College UK Cambridge Centre podcast. In this Integrated Cancer Medicine Research in Focus series, I talk to various ICM members about their research and how it is supported by the vision of the Mark Foundation Institute for Integrated Cancer Medicine. MFICM research uses cutting-edge analytics to maximise the use of diverse high-volume datasets and by capturing cancer heterogeneity in time and space in patients receiving active treatment. Integrated cancer medicine aims to transform the way the world treats cancer by affecting patients along their treatment pathway and ultimately accelerate cures. Today I have with me George Vassiliou, and we're going to talk about his research on clonal haematopoiesis and a new clinic that he has recently set up. George Vassiliou is CRUK Senior Clinical Fellow and Professor of Haematological Medicine at the University of Cambridge. He is also a member of faculty at the Wellcome-MRC Cambridge Stem Cell Institute and a consultant haematologist at Cambridge University Hospitals. Hi George, thanks so much for joining me today. You have a collection of roles that I have just mentioned. Would you just like to outline what some of them entail for me?
Yeah, so CRUK funded me to transition to a permanent position at the University of Cambridge. So CRUK funds people like me who are clinicians who are interested in medical research to take them through the training stages of their career until they sort of achieve something worthy of becoming a professor at the university, which I got there in the end. So I'm now a professor at the University of Cambridge where I do research, also do a bit of teaching, and I also get involved in other university-related activities. My laboratory is based at the Wellcome-MRC Cambridge Stem Cell Institute, where we do most of our experimental work investigating blood cancers and clonal haematopoiesis that we'll come to. But I also see patients once a week, sometimes outside that day, with blood cancers, and establish this clinic, a new clinic that we'll also discuss later at Addenbrooke's Hospital.
You wear many hats.
Yes.
So tell me, what does an average day or what does an average week entail for you? A mixture of all of those different rules?
Yeah, so I would say that Tuesday is my clinic day, and I spend most of the morning and some of the afternoon at the clinic. And the clinics since COVID have changed slightly. We see a lot of patients remotely, and only the ones that need to come and see us in person do so. Outside that time, most of the time I look after my team at the Cambridge Stem Cell Institute. I do have also regular meetings with colleagues, faculty, establishing collaborations, applying for grants, and a lot of thinking about what do we need to do next. So I must say, I spend a lot of hours on what I do, but I don't even consider it work. I feel naturally as being where I want to be and doing stuff I want to be doing and enjoying myself. And, even if I think about things, most of my waking hours, I don't feel that this is cumbersome or tiring. I just love doing it.
How lovely to have that as your vocation.
I feel fortunate. And I live very close to work. So I walk to work or cycle. It's something that I feel is worthwhile doing, and I'm also enjoying doing it. So it's great.
Tell me a bit about clonal haematopoiesis and why it's so important in the study of haematological malignancies.
I start from why we ever looked for this phenomenon of clonal haematopoiesis. I'll explain what it is in a minute. But in around 2012, 13, I remember distinctly a patient of mine who came to Addenbrooke's Hospital very unwell with acute myeloid leukemia, which is an aggressive blood cancer. And their life was in danger. Thankfully, we got them treated and they did well in the end. But at the time, I asked, well, how long have you been feeling unwell? And it transpired that the patient had only been feeling unwell for something like 10 days, a week, 10 days. And as little as 3 or 4 weeks before, he had run a half marathon.
Wow.
Now, I was aware that, of course, that the disease presents suddenly. But I always imagined that there must be something going wrong with your health leading up to you turning up in hospital. And this told me, well, sometimes there's nothing much wrong with your health if you can run a half marathon. And I sort of thought, well, there must be something. You can't just go from nothing to this overwhelming leukemia that's everywhere in your body, just like that. So others have had the same thought around that time. But doing our own way, we imagine that there must be some people out there that may have, let's say, the seeds of leukemia. And because by that period, we had identified the genetic changes that start or lead to leukemia, we sort of thought, let's go and have a look at a large number of people and see if some of them have these genetic changes. And we looked at, in our group, 4,500 people, and we only selected 15 specific changes because it was easy to look for them and it was affordable with the limited budget I had at the time to look for them. And we looked for them and we found them in a surprisingly high proportion of people. And what we found was also identified by 3 other groups in the United States around the same time, end of 2014, beginning of 2015. And it's something that people imagined beforehand may be present, but overwhelmingly, nobody imagined how common it is. This is clonal haematopoiesis. So if we look at it now, instead of looking at it from the leukemia backwards, if we look at it from the start, essentially as we age, all our blood stem cells, they are the cells that make our blood. They are long-lived cells. They're in our body for all of our life, making blood day in, day out. Now, all those cells, like every other cell near enough in our body, they have a long string of DNA inside them, and they protect it, they cherish it, and they protect it to stop it from changing because that's dangerous. Yep. But however well they try, some changes, which we call mutations, creep in. Most of the time, these mutations do not really lead to any detriment or any gain to the cell. Occasionally, they lead to detriment, but rarely they give the cell like an inner fitness to grow more than the other cells grow next to it. And this is what clonal haematopoiesis is. Normally, we have 100 to 200,000 blood stem cells that make actually trillions of blood cells every day. It's a massive production factory. But these cells keep making blood and making blood. If one of them gets a mutation of this type, it will expand and expand and expand and take up the space of what was 100,000. Instead of every one of them making their fair proportion of the blood, this cell can make 1, 2, 10, 50, even sometimes close to 100%. All the blood comes from this one cell that expanded. Now, interestingly, or the most common types of this, when we say types, by the way, what I mean by types, we mean what is the mutation, which gene is behind the growth. There's actually about 10 genes are responsible for 95% plus of all cases. And as I said, this is a common phenomenon. We find it if we look carefully, in more than half of all people age 70 or older. And if we look really deeply, we probably find it in everyone, because everyone gets these gene changes with time. But our research over the years now, because we've been looking into this phenomenon, has established a number of things that, depending on the gene, the cells may grow faster or even faster or slightly slower, depending on the specific gene. They tend to, over time, have a steady trajectory of growth. So the gene dictates how fast, but that speed, that rate of expansion is fairly steady over time for most genes. But the key point here is that this is really common. And leukemia, acute myeloid leukemia, for example, it's a group of related cancers. Collectively, we call them the myeloid cancers. I guess I can mention some of them because people may relate to that. So I said acute myeloid leukemia, myelodysplastic syndromes, myeloproliferative neoplasms, and chronic myelomonocytic leukemia. So these are all in the same category. What is striking about them is they all start as clonal haematopoiesis. And what happens next decides which one of those you get. But overall, only 1 or 2% of people with clonal haematopoiesis will ever get any of these leukemias or blood cancers. And what we've been able to determine over the years is that those who are more likely to become cancer, we can identify them years before they get cancer. We're not perfect at doing that. The way we do it is the following. We can basically say, this person has so much percent of getting cancer, and this person has a lower or a higher. It's rare that we're going to say this person is definitely going to get cancer, or this person is definitely not going to get cancer. But nevertheless, it's quite helpful to be able to know the risk, because what we're trying to do in our clinic in Cambridge. And also now I've worked to organize a lot of hematologists around the UK with an interest. I've reached out to them, and together we made like a grouping. In fact, we had our first in-person meet. We'll be meeting online for a few months now, but for almost a year. But we met in person on Monday, just gone down at the University College London. And we're basically bringing ourselves into this grouping to try and understand this new field, which is we find the people at risk of leukemia, and our aim is to stop them getting leukemia. First, how do we do that? I mean, that is experimental work, both in terms of genetic tests, experiments in the lab, even with mouse models. All of these things where many of us are working to find how we stop progression in those who are at risk. But another very more practical thing is, how do we find those at risk? Because they're sitting at home, they don't feel ill. Remember, even very close to leukemia, you don't really feel ill. And then if we find them, we find people with the clonal haematopoiesis. And we have now a website, even online, that you can go and input all the findings and you get to a risk profile. But from that is still a personal choice to say, what is a high risk? For example, if I'm 85 and I have a 10% risk of getting leukemia in the next 15 years, I may say, well, I'll ignore that. But if I'm 20 and I have a 20% risk, I may not want to ignore that. Equally, if I'm a much higher risk, like a 50 or 60 or 70%, then I want to be doing something about it now. So you can understand the factors involved. Are you otherwise healthy? How old you are? Do you have other things in the way of us, for example, treating you with something which is initially going to be experimental? So these are the calculations we have to make, because it's easy to decide to treat someone when they got a serious life-threatening disease. The obvious thing is to treat them. But when they just at risk of something and they're currently well, anything you might want to give them has to be very measured and very calculated to not make them sick now if they weren't going to become sick in the first place anyway. So
a bit counterproductive.
Exactly. Yeah. But actually, we still think that we're finding in our more recent research and published research that we are very close to completing, that there are some treatments that we might be able to use that are now already being used for other conditions. So they have a good safety record, and we can perhaps start studies. And because unfortunately, this has to start with studies. I cannot, like someone turns up in my NHS clinic and say, oh, I think this drug will work. There it is. I cannot do that. That would be wrong. So what the way in is we find the people, we make a case to an ethics committee and to a funding body. We have an idea that this drug, which is tolerated well, may prevent this type of clonal haematopoiesis to progress to leukemia. And we would like to invite people to take this drug if they want to. So that would have to be vetted and checked. And if others, not me, agree that, yeah, this is worth doing, that's how we're going to start this process. So that's what we're setting up our clinic to do. But many things in science take many years, decades sometimes, to get there. But the way we're going about this specific question is we're already looking for things that can happen sooner, because we want to use drugs that are already out there, for example. So without sounding wildly optimistic, I expect that our clinic that we've established, together with, say, let's say, parallel clinics elsewhere in the UK, because we need the collective, not just to find the numbers of people who need to do the studies, but to also help each other think around the problems, because each one has their own perspective and their own valuable input. But I think, coming back, that I expect within the next 2 years or maybe 3, we will be able to start the clinical study. And of course, the readout of the study, in other words, the positive outcome I want to see, is that less people progress to these blood cancers than the people that will follow up but don't give them the treatment. So that would be the initial study. But we're very excited because it's a new field, a new area.
Yeah. And when did your clinic open?
Our clinic opened about a year ago now. The numbers of patients coming is this small, and it's for the reason I mentioned, and I didn't expand on, is how do we find them?
Yeah.
Right? How do we find them? There is a number of issues to think through when you're looking to find them. Let's say that I tell you what I just told you and say, would you like me to take a blood sample from you and see if you've got something? And the chances are you don't, but say you did have something. then I will then tell you, well, this puts you at this much risk, and then I have to do something about it. You might tell me, actually, George, thank you very much. I don't want to, I'm just happy here. I don't want to find that out. But if I told you that what you have, I have a treatment here. So before I look for it, I can tell you for this specific thing, we'll have a treatment here. And we think it's promising. And I show you the data, the reason. So we can say then we check you. If you don't have it, great. But if you have it, you might be able to have this treatment. And I think it's only in that context that it would make sense for people to be checked.
Yeah.
Now, there's a number of other things around this that I didn't go into, but essentially, we have started doing something more simple. So these are all blood conditions, and having this chronic haematopoiesis in your blood can lead to very subtle changes in your blood test. You don't know it, and maybe your doctor doesn't notice it because it's only so mild. But we have built already some, let's say, machine learning or artificial intelligence tools that take all the information, put it together, and are telling us this person may have chronic haematopoiesis. It's not telling us what type or if it's a high risk. It's telling us may. At the moment, if we were to apply these tools that we've built, we will dramatically reduce the numbers that we will invite to have the test. But let me explain that as well. So let's say out of 100 people, our test will only invite maybe 5 to have the test. But even amongst those 5, most of them, in fact, usually all 5, will not have the high risk problem. We'll have to screen maybe 300-400 to find one that has the high risk. Okay, so that's, leukemia and the group of leukemias we talked about occurring about 1 to 2 people per 10,000 per year. So they're not common diseases, but they can be devastating diseases.
Yeah.
So that's the context. You try to prevent something quite bad, and you're trying to prevent it at a stage where the person is well. Overall, it's an exercise that we're going about carefully, and I hope, and thoughtfully, and we are going to get there, I'm sure, and offer some treatments to people that are sensible, don't cause them trouble, and reduce their risk. But like anything in medicine, it would take us some time, but I think slightly less time than other things have taken in medicine.
Yeah, that's good. It's a bit like searching for a needle in a haystack, isn't it? You just want those that are going to be good for your study, but you're going to have to screen so many people.
Exactly. But with a needle in a haystack, so if you're looking at, I'll tell you the example. Say you have a lot of hay and a few needles. If you had something which told you, well, the hay is not completely straight, the needle is completely straight. So that first pass is going to tell you this thing looks straight enough to be a needle. So just check if it's a needle. That's what we want to do. It's a pre-test for those things that look like a needle. And they're definitely not hay. Yeah. But even they, no, not definitely, they're unlikely to be hay, but even they may still be hay because it happens to be a straight piece of hay. So a pre-test, then a test. The test gives you the risk, and then you decide if it warrants some sort of treatment or intervention or even just careful monitoring. Sometimes it's enough to keep a close eye and check because these clones grow and grow and grow. And if they reach a certain size, it's only then that you say, well, now your risk has come up to this. When we first tested, it was low, but now it's higher. So that's another way we can deal with this.
And so can I ask, are there other clonal haematopoiesis clinics opened already or opening in the future?
So in the US, there is multiple. Now, the reason there's multiple in the US is because the test that finds people with chronic haematopoiesis is done much more freely in the US. So people are found by their doctors, let's say semi-coincidentally, not completely coincidentally, because why did you do the test in the first place? In the US, it's customary to do a series of tests in a certain clinical presentation. And this test that finds people with chronic haematopoiesis has entered the required test list for many indications. In the UK, we don't do this very often. We only do it if you already have a suspicion that there is a blood cancer or close to it. So as a result, only a few people are identified. And as a result, there is not many clinics yet in the UK or in Europe. But in the US, there's many more clinics and many more patients. So we are trying to make the case that it's worth doing these tests if we are able to communicate to the world that this phenomenon is common and usually doesn't matter because most people will get it. And we're only looking for those for whom it does matter. So we remove, let's say, the concern or the fear or the anxiety. Essentially, if you're 70, 50% of the time you have this. So it's not really such bad news. It's probably worse to have like diabetes than to have this. So the moment we can communicate that, I think people do it. And the other thing we're doing is the way I said to you that we select who has the test, but also in Cambridge, we're building a very simple and cheap test that can be done without big cost to the NHS. And it sort of pre-selects the cases with the higher risk genes. Instead of finding all of them, just focuses on the smaller number. So with that test that we're building now, most people will not have anything. It's only those who have something that will have a positive result. So for example, let us take you as the example. If you had this test, you're already unlikely to have any clonal haematopoiesis, but you're super unlikely to have the genes that are on this test. So the likelihood is you have this test, nothing's going to be found unless it's worth knowing about. Yeah. So we're building this test and automating it, and we're even adapting it to a robot. So actually, you can take your blood sample, put it in the robot, and the robot generates the data that's needed. So automating the whole process to make it simple, affordable, and also easier to communicate to potential takers.
Yeah, it sounds absolutely amazing. Kind of groundbreaking, really.
Well, it is. We first, as I say, we don't want to take sole credit because this is a field and there's colleagues in other places who have contributed. But we are amongst the people who made a significant chunk of their contribution, and we're very excited and fortunate that they are able to be in a position where we can affect change. And if you look around you, what's happening in the world, a lot of changes across our planet, across our healthcare systems, the way developed treatments are changing. And I think prevention is going to be changing in ways that we cannot foresee even today.
Absolutely, I would agree with you. And so you talked a little bit about genetics and looking for the biomarkers or the mutations. Yeah. So are you integrating different data streams when you're doing these tests and looking at clonal haematopoiesis? So can you talk to what data you need?
First thing to say, which a lot of people ask me, because we talk genetics, people immediately think inheritance. But it's very clear to say that there is a very small number of cases of leukemia or these related conditions that I talked about that you get because you had an inherited predisposition. The vast majority happen by chance to people with no predisposition. And what we're looking for is not predisposition. So if I have the test and I have one of these clonal haematopoiesis mutations, that means nothing to my family. That's something that happened to me during my life in one of my cells and didn't happen in the cells of my son or my cousin or my brother or my sister. So that's a critical component. We do have a separate clinical activity that we're going to build to a clinic that's close to the clinic we've been talking about, where we will invite the families who have these rare predisposition mutations and look after them in similar ways to the people who don't have predisposition, but it's a separate thing. So that needs to be clear to people. We're not looking, the test we're doing has no relevance to your family. It's just for you. That's the simplest way to say it. We're not looking for something that runs in families. Now, in terms of data streams, so for example, this algorithm or software, if you like, or predictive model called MN, myeloid neoplasms, it means predict. It's a website that's hosted at the University of Cambridge. Someone can go in there, enter their genetic changes, but also their full blood count, the basic biochemistry tests, and some other more elaborate biochemistry tests if they have them. And our software takes all of them into account to predict your risk. So there's the types of data streams that we're using, that we're integrating to define risk. But there is additional ones that we are trying to incorporate into this model to improve our ability to predict even more. So for example, certain proteins in the blood that we don't measure routinely, we already have reason to believe that if we had measured them, we would build a better test. And we're trying to understand them. Another type of data stream that we are incorporating, and is not gone into the mainstream yet, is images of blood cells. So you can take a blood sample, you can make a blood smear, and you can stain it with a stain, look at it under the microscope. Now, if you or I, let's say, had the right training and looked at it under the microscope, we would struggle to find subtle things in people with clot haematopoiesis. Sometimes we find them. Most of the time, the differences to the normal, let's say, would be too subtle. So we've built something we call computer vision, where the computer goes and it individually, let's say, digitally cuts out every single cell on the slide, every single cell for which there's a good image, let's say, because sometimes cells are on top of each other in the slide and you ignore them. Only the ones with good image. You take them out and you do all sorts of like measurements. There's this long, is this dense in color, is this shape. The computer takes all that information in and does more a statistical analysis that your mixture of cells is slightly outside of normal. And that can add to our ability to find those who make up clot haematopoiesis. So that is completing. We only published this last year, and we only did it in people with established blood cancers. We could distinguish one type from another using this computer vision. It's not gone to clot haematopoiesis yet, but we are in the process of doing it for finding people with clot haematopoiesis. Another way we call it data, when we look to find treatments, we're doing a whole lot of experimental approaches, and they have a different sets of data types. These can range from DNA sequencing to RNA sequencing to drug screens on cells and what they're sensitive to CRISPR screens, where you use innovative technology to find which genes the cells need to grow. Because for us, those are the genes to go after, what to stop them growing. Also, something called metabolomics, where we measure different metabolites in the cells. And as we're finding that these cells that grow faster than others, they rely on different types of nutrients. So we could manipulate, not necessarily what you eat, because that would be a difficult one, but how what you eat is metabolized and treated by the body to remove the fuel from fueling the fire of the cells, let's say. So there's all sorts of different types of data. And around that, we were recently fortunate to be awarded a big grant from the Leukemia Lymphoma Society, a US-based charity, and Blood Cancer UK. So together, it's a 2/3 US, 1/3 UK funding envelope. I'm leading a program to prevent myeloid cancers. As well as me, there's 8 world-leading, I'd say, scientists from Cambridge or affiliated institutes with Cambridge University, like the Science Institute. So together, we developed a program that would take us through the steps needed to make progress. Identify the patients that are at risk, identify modifiers of the risk using human genetics, do experiments to understand how cells grow and why, and then develop therapies. So all of these 4 programs have a 5-year envelope now to develop them with 8 other colleagues. We are also getting funding for a specialist nurse that will help us organize a lot of things, develop booklets, for example, for handing out to people to understand what we're talking about with clot haematopoiesis, organize ourselves nationally with our colleagues I mentioned earlier, our meetings, our communications, etc. So yeah, we're on a good footing, let's say, at the moment.
And so all of this will feed into sort of the normal standard of care for haematological cancer. And it sounds like it could potentially have huge impact on patient outcomes.
I mean, essentially, it's the old dictum where prevention is better than cure. So we're hoping that we will be preventing some of these cancers. I mean, I didn't go anywhere near the fact that it costs a lot of money to treat each individual patient. We have not really done careful financial calculations as yet. In other words, okay, you save people's lives and maybe you save them from developing leukemia if you are successful, but what is the cost? Because everything, unfortunately, these days has a cost. For example, a new drug has to be costed before it's approved. A similar exercise has to be made for what we're doing. What I'm certain, though, about is that in the end, the financial calculation will be favorable. I'll explain how. If it's very cheap, let's say, to prevent blood cancers and very safe, we will treat people at slightly lower risk. And if it's very expensive, we will simply treat people at high risk because for them, the eventual cost calculation is favorable. So I think essentially it has to be done, the cost calculation, but what it will tell us is something about the level of risk someone has to be at before you intervene, rather than you must never do this or you must do it to everyone. So I'm quite optimistic that the financial, which are in the process of also doing, will tell us something that will allow us to do what we're doing, but just tell us who to target it to.
Yeah, that makes perfect sense. Yeah. And obviously I'm from the Integrated Cancer Medicine Programme. So I want to talk a little bit how you feel this fits in with integrating data and the integrated cancer medicine paradigm, as it were.
Yeah.
And where you feel that it's leading you, that paradigm, sort of in the next 5 to 10 years, thinking that far ahead.
Yeah. Within the Cambridge Cancer Centre, we have a lot of different cancer types and programs specializing in aspects of how you deal with cancer or diagnose or treat. I think our specific program has a lot of overlaps with a lot of what others are doing. I would say the one program that will have to spring to mind is screening for esophageal cancer led by Rebecca Fitzgerald, where there are similar ways to predict who is at high risk and to target them. The one important difference for esophageal cancer is that it's already an established treatment. So if you're at high risk, you have a treatment. It's not trivial, but it's not really bad, let's say, the treatment. People tolerate it and it's effective. For many cancers, like, let's say, pancreatic cancer, sometimes liver cancer, it's not easy to find something, cut it out. So in our world of hematology, we cannot cut it out. We have to control it. And I suspect that this is where our work will talk to other things. We hope to find ways to medically control pre-cancerous lesions. And again, I didn't go into it, but what we found in hematology, the hematologists were the first to find clonal haematopoiesis as a pre-cancerous phenomenon because it's easy to take a blood sample. But soon after us, many other cancer types were found to be developing in exactly the same way. So there is lots of cells that look after refreshing the tissue. If we take skin was the next example. So the skin cells, we lose them all the time. So somebody has to keep making new skin cells. And that's the skin stem cells. If you look at the skin stem cells, their fate is similar to the blood stem cell. They get genetic mutations, they grow in clones, and those clones can progress towards skin cancer. And the same was found for all sorts of other tissues now. Wherever you look near enough in the body, you find these lesions. So we think and hope that there will be cross-cutting themes. In other words, something that stops a blood stem cell from growing abnormally may stop another stem cell or another tissue. And so all of these data sets, all of these findings, we will seek out our colleagues in other cancers who are collecting similar data to find cross-cutting themes and potentially interact together. Again, we're fortunate in hematology because all these things I told you, how we find who has ABCD, is easy because we take a sample. On the solid cancer world, obviously we have this circulating tumor DNA or circulating cell-free DNA where it might take us places. And as you may be aware, many are already trying to use this to find who might have cancer or sometimes pre-cancer, but at the moment it's more cancer. But that might morph into a type of test similar to what we're doing. And all of the data sets I mentioned are pertinent, for metabolism in cancer, DNA, RNA, all of those things, predictive tools. You could take any cancer and build their equivalent data set. But I don't know if that answers quite your question.
I think the way that we integrate data across different cancer types and also a patient's data across their entire story, their clinical informatics, their imaging, their genomics and biopsy, pathology.
Yeah.
I think it's really important. I think we're doing it more and more and more in the treatment of all cancers. And so it's really exciting to see how treatments from one can transfer to another, and especially with the use of drugs that are already out there and already proven safe, because obviously that takes a huge layer of risk out of it for a patient receiving treatment. So it's really interesting to see how it might overlap with other disease areas and other cancers.
And one area where hematology or this type of hematology has not ventured into is radiology. We do radiology for conditions like lymphoma, But for leukemias, I mean, we do radiology, but it's not to find where the leukemia is. We know the leukemia is around the body. It's not to see if they have a chest infection, our patients, or something. But we are now looking at X imaging in the context of chronic haematopoiesis. So we're trying to understand how the bones of our bodies, where our blood is being made, they're made of hard bone around the outside mostly, and more spongy bone on the inside, and that's where the blood is being made. And we have early evidence to suggest that the bone itself and the fatty cells in the bone marrow help to the chronic haematopoiesis to make it expand and grow. And we hope that we might be able to find X-ray or radiological ways to find who may have significant chronic haematopoiesis or not. But that's, again, in its infancy. But we are trying to do it with people from the UK Biobank, because they all, about 50 or 60,000 of them, have MRIs of their bones, and we also know if they have chronic haematopoiesis or not. So we're trying to learn from that.
So you already have that data at your fingertips?
Yeah, we're able to access that data. Yeah, it's amazing. The UK Biobank is a tremendous resource. It helped us a lot with our research, because we can find the people with chronic haematopoiesis, but they also know a whole lot else about, and we can try and understand it. Yeah.
So my last question really is, where do you see your research taking you in the next 5 to 10 years? And you've touched on it a bit already.
So hopefully it's taking me nowhere, because I intend to stay in Cambridge.
I think that's good news for us.
But in terms of metaphorically where it's taking me, I hope that within the next 2 to 3 years, we will start clinical studies. From what I know from our research, I think we have promising data that will lead us to clinical studies. I hope that we will be able to communicate to the general population that doing tests like the ones I'm proposing is reasonable and not to be feared. Because in the past, for example, you may have a blood test because you feel tired and find that you have a serious illness. So for any test you do to the human body, there is always a risk. And this is no different. It's just that whenever you talk about genes, people can get the wrong end of the stick. So a campaign of appropriate information to help take our message out there will help not just us in hematology, but in a broader way, the area of cancer in general, able to communicate what these gene tests that has been the big explosion, and how we got to chronic haematopoiesis in the first place, how they can be used safely and informatively, and they shouldn't be feared. So yeah, that's aspiration, is to be able to find the people who have pre-leukemia and put them into studies to prevent pre-leukemia. At the same time, I should say, some of what we're finding is actually relevant even to leukemia itself. Some of the treatments that we're finding stop the pre-leukemia may already be applicable. And in parallel to my pre-leukemia work, we continue to do leukemia work, and we help to develop new drugs in leukemia. So we're working across the spectrum. But I would say what is now the most exciting and attracting the most interest is the pre-leukemia work, because of its novelty. We have been trying with some success, but recently, to develop new drugs for leukemia. There's lots to be done, but because of its novelty, this pre-leukemia aspect and the questions it raises, it attracts interest, not just from patients and families, but from the wider public and researchers.
George, it's been so interesting to talk to you this afternoon. Thank you so much for joining me on this podcast.
Thank you very much for your time.
If you want to find out more about the work of the Mark Foundation Institute for Integrated Cancer Medicine, please visit our website at www.integratedcancermedicine.org, where you can find details of the ICM vision, all the current research, clinical trials, resources, publications, and team information. You can keep up to date with our latest news and events, and you can also sign up for our newsletter. If you would like more information about the work of the CRUK Cambridge Centre, please go to www.crukcambridgecentre.org.uk, or you can connect with us on Twitter using our handle @CRUKCamCentre. Thanks for listening, and do join us again soon.